all and welcome again. The spinopelvic relationship, or what we call the lumbo-pelvic complex interaction, has an important bearing on kinematic positioning of total hip arthroplasty. As we already discussed on the main video of THR, this video is going to provide supplementary information on the same spinopelvic interaction. The viewers are highly encouraged to watch the original video, else this video will appear to be a bit out of place. The primary myth is that if you place a total hip arthroplasty in anatomical position, it will last the longest and will also not dislocate. But we know that somewhere around only 50% of the acetabular cups are positioned in the safe zone as proposed by the Levinek, but only few of them dislocate. On the contrary, most of the dislocating hips are within the safe zones. What is this mystery? This mystery needs to be solved, one, on the basis of spinopelvic interaction, and also there are other parameters which we have already discussed in total hip arthroplasty. The agenda for today's video is first understanding the patient morphotype in accordance with the spinopelvic relationships or the lumbopelvic complex interaction. Then we will build on the improvisations needed for the safe zones. If we have any other available armamentarium like different types of acetabular cuffs, we will also try to understand whether they will help us or not. And is the acetabular cuff alignment all the panacea of dislocating THRs, or there is something else also? We'll try to delve into that aspect also. We need to first understand the difference between balance and alignment. Balance is a dynamic concept that reflects how the body can adapt its center of mass and gravity while we are in motion. The biomechanical principles help us understand that our muscles dynamically and ergonomically place our body in a conus of energy, but if we fall out of this conus, then the work of muscles increase, producing fatigue and pain. Now, this concept is more related to the spine surgery. Alignment is a static concept where the different body parts are measured in relative position to each other, say for example, as we see them on a radiograph. Now, SVA has been classically used to assess the alignment of spine, while pelvic modifiers like SSA, T1, pelvic angle, or the TPA or the global tilt have been recently added to add to the complexity of spine reconstructions. Now we know that if the thoracic kyphosis is increased, like in the third figure on the right side, then various compensatory mechanisms come into play, like the pelvic retrotorsion or the backward tilt of the sacrum, hip knee flexion, posterior truncal shift as we see in this patient, and cervical hyperlordosis. Now, for the purpose of acetabular reconstruction, we are not much worried about all these parameters. We need to focus on the pelvic inclination, sacral slope, and pelvic tilt. And pelvic inclination is a fixed parameter for a particular person by itself. And it comprises of two variables, that is the sacral slope and pelvic tilt. Now, being a static parameter for a particular person, it is given the maximum importance, and most of the classifications are centered around understanding the PI. As we understood that pelvic incidence has got the central place in understanding the lumbopelvic complex, so based on the PI with the simplistic relationship that a high PI patient will have a wide pelvis and a high sacral slope. This we need to understand. If the PI is high or has a higher degree, then the sacral slope will also be high. This produces spines that are more curvy and have long lumbar lordosis with a cranial lumbar apex. These spines fall in the type 4 of the Bruce Lee classification, who divided sagittal profile of a spine into 4 types. For our understanding, type 1 and type 2 have a stiffer LPC or the lumbopelvic complex. This lumbopelvic junction is stiffer in type 1 and type 2. But these patients have a compensatory high hip range of motion. These patients are called hip users, whereas type 3 and type 4 have high PI and have a very curvy spine which is either flexible or hyperflexible, which can adapt to changed posture requirements, and these patients are called spine users. We have seen the most important static relationship in terms of LPC. A high pelvic incidence equates to the high sacral slope and more curvy spine. That is it from understanding the static position. What is more important to be understood is the 3D orientation of the acetabulum with respect to truncal equilibrium. That means the dynamic relationship. It is seen that when we go from standing to sitting position, the hip flexes. This is the normal disposition. This is our standing position. This is sitting position. The arrow tells the hip flexion position. During standing, the hip was extended and it flexes during the sitting position. What changes in all this is the sacral slope and the pelvic tilt. We will concentrate only on the sacral slope. The sacral slope is very high while standing, which changes to very small angle on sitting. What other thing changes is the proposition of the pelvis. See the sacrum, which is very horizontal, causing the sacral promontory to protrude at an angle which is very significant. But while sitting, the pelvis retroverts or retrotorts. This retroversion is measured with respect to the position of sacral promontory. Now the sacral promontory goes posteriorly, reducing the lumbar lordosis. See, the spine becomes more straight. Now, during all this change, the acetabulum position changes, and this is the crux of understanding the positioning of acetabulum or kinematic alignment of total hip arthroplasty. With the posterior tilt of pelvis, there is biological opening of acetabulum. Now, if this is sort of the acetabulum of our pelvis, now this is the right acetabulum. During standing, the acetabulum is more closed, while as we sit, the acetabulum opens up. It has more anteversion. And now a hip femoral head which is placed in the acetabulum will have much more space anteriorly if the acetabulum is opened up as it occurs in the sitting position. There is increased anterior clearance when we sit. In the standing position, there is reduced anterior clearance, and this clearance changes because of the sitting position and change in the sacral slope and the pelvic tilt. The acetabulum opens up and the femoral head is much more cleared anteriorly, preventing any anterior impingement and damage to the tissues. If this relationship is lost, then there will be anterior impingement and the hip will dislocate posteriorly because the femoral head will be forced posteriorly. We have already understood the two most important concepts that will be needed in kinematic placement of acetabular cup. That is the static relationship of high PI to high SS or low PI to low SS, and the important concept of acetabular opening as we go from standing to sitting position. This slide is only for the interested reader who wants to know the different researchers who have produced various classifications in understanding this LPC. But as I find it, all these are too complicated to understand the exact relationship. We will only use our two concepts, the static and the dynamic LPC concept, to build up the kinematic alignment of acetabular cup positioning. Now we will further build up the understanding based on our static and dynamic concepts of lumbopelvic complex. We will divide the patients into two different types for clearer understanding. One are the hip users. Who are they? These patients have low PI and low sacral slope. Obviously, the static relationships told us that a low PI will have low sacral slope. Now, what does low sacral slope means? In the dynamic concept, we understood that while sitting, the sacral slope reduces and the lumbar lordosis also reduces. Now, this leads to opening up of the acetabulum. That means a person with low sacral slope will have an increased anteversion in the acetabulum and increased inclination, or what we call the increased acetabular anti-inclination. Now, because they already have increased anteversion and increased inclination, so the femoral head will be more free to move about. Because these patients have low sacral slope, so the spine will not be able to compensate. The sacrum was horizontal on standing and it used to shift to the vertical position. That means low sacral slope. Now this compensation cannot occur in those persons who already have low sacral slope. So if you have low sacral slope, the spine cannot move, it is more stiff. So this function is overtaken by the hip joint because it is more open, the acetabulum is open, so femoral head can more freely move about. So these patients are called hip users. Contrary to them, the persons who have high pelvic incidence and high sacral slope will have more curvy spines, the type 4 spines. Now these patients are easily able to change the sacral slope from standing to sitting. Now, because the spine moves so much, so the hip joint is not required to be moved. The other thing is that if the sacral slope is more, the acetabulum is more closed. So the femoral head is more covered anteriorly. So it will be more fixed. So these patients use their spine more than the hip joint. Now we are ready to kinematically place our acetabular cup by understanding the concepts of lumbopelvic complex, both static and the dynamic. Now see the first scenario. A patient who has low pelvic incidence, that means he has low sacral slope. Correct. Now, if the person already has low sacral slope, that means he cannot further retrovert his sacrum. The sacrum cannot tilt back when the person is going from standing to sitting position. This needs to be understood very clearly. Person with low sacral slope cannot further retrovert their sacrum, and hence they will have acetabulum in a more closed position. That means the acetabulum will not be much opened, and while sitting the acetabulum cannot further open because the sacrum cannot tilt back. These patients already have hypermobile hips. They are the hip users, as we already saw. These patients are found to have less of acetabular version. Anatomically, these pelvis have less acetabular version, and unfortunately, because the sacrum cannot tilt back further, or that the sacrum cannot retrovert, the acetabulum cannot open up. If the acetabulum cannot open up, the femoral head will get impinged anteriorly. If there is anterior impingement, it leads to shift of the femoral head posteriorly because it is impinging anteriorly. So there will be posterior edge loading, and the acetabulum, because of low version, is not able to provide good posterior coverage, and the femoral head will dislocate posteriorly. So this happens while the person is sitting. Such patients need increased acetabular anti-inclination while doing a total hip arthroplasty. We are discussing very atypical and difficult scenarios. To keep the wavelengths matching, I would like to reiterate that we are discussing scenarios where there is isolated pelvic anatomical variation. We are still not discussing cases where the spine is stiff. So we are placing our acetabulum in kinematic alignment only according to the differences in the pelvic incidence which we find in normal population. Now the first scenario was where the pelvic incidence was low and the sacral slope was low, so that the patient was unable to provide posterior coverage to the hip joint while sitting. So it was getting posteriorly unstable and getting anterior impingement. Now we consider a scenario where the spine is hypermobile. Now hypermobile cases come when there is increased pelvic incidence, so there is already increased sacral slope. What does this mean? These patients are spine users. That means their pelvis will be moving a lot on the femoral head. The acetabulum is rotating around the femoral head. Now consider two scenarios. First one is when the patient is sitting. During sitting, we know that the acetabulum will open up. So it will provide less of anterior coverage while more of the posterior coverage. If this movement is too much, if the patient is hyperflexible, then what will happen is that there will be posterior impingement while the femoral head would escape anteriorly. In extremis, this may lead to anterior dislocation. While consider the other scenario, now the same patient is standing. Because of excessive movement of the pelvis will go into anteversion on standing. If it goes into anteversion on standing, the acetabulum would close and there will be anterior impingement and the femoral head would tend to dislocate posteriorly. In the first scenario, when the patient is standing, we would like our cup to be placed in more of retroversion, less of anteversion, more of retroversion. But if we place cup in less of anteversion, the same patient on standing will develop anterior impingement. So you cannot change the position of acetabular cup to provide increased anterior or posterior coverage for patient while standing or sitting. Now these scenario may develop over a period of time also later in the life, and hence the cup may be later unstable and the patient will have late dislocations. It is recommended that if the patient is having a hyperflexible spine but a balanced one, that means the head is sitting atop his pelvis, then put the cup in absolutely anatomical version. But if the patient is having hyperflexible but unbalanced spine, this is the scenario where you would like to send the patient to your spine surgeon, asking him for the help so that he puts the spine back in the normal mobility state, or he may fuse some of the components and reduce the sacral slope so that you can do a THR later and put the acetabulum in the correct position, preventing sort of dislocations or impingement and increasing the life of the implant. Now we have already understood the simplest scenarios of low PI and high PI, how the composition changes with respect to them. Come to the more complex situation where the lumbar spine is stiff. What does it mean? The spine pathology or the degeneration always affects the hip joint, which is called the spine hip syndrome, which is similar to the hepatorenal syndrome, where like a liver disease would influence the renal function or even vice versa. Now, what is meant by the spine stiffness? The change in sacral slope is less than 10 degrees in these patients. Now, where this position, we will consider two different scenarios. When the patient is having a pelvis in anteversion. Now, what does anteversion means? The sacral promontory is pointing anteriorly. That means the sacral slope is high. Now, we already know from our dynamic relationship of LPC that a high sacral slope means acetabulum in more closed position. That means the femoral head will have increased anterior coverage and less posterior coverage. Now, in these patients, because the spine is stiff, just understand that an increased sacral slope will not reduce while sitting. The sacrum has to retrovert on sitting, but these patients are having a stiff spine. The change in sacral slope is less than 10 degrees. So whether you stand or sit, the sacrum will still be in the anteverted position. The sacral promontory or the sacral slope will be in anteversion or high sacral slope. That means acetabulum will be closed. These patients, when they go to sitting position, will lead to anterior impingement and again posterior edge loading and posterior dislocation because of reduced posterior coverage. Now, uh, to overcome this situation, you need to place the acetabulum in higher anteversion. Now, this is a reverse situation. You see, when we had a patient with plain low pelvic incidence, that means low sacral slope, we put the acetabulum in higher anteversion. But here with the spine stiffness, the scenario has reversed. And we need to understand this in totality. Now come to the other scenario where the person is having still a stiff spine, that means change in sacral slope less than 10 degree, but he has fused spine in pelvic retrotorsion. Now this is a more common scenario which we see in bad spine surgeries or flat back syndrome. Also this thing you can see in cases with ankylosing spondylitis. Now these patients have already a sacral slope which is already less. Now we know that in patients who have less sacral slope, the acetabulum is already open. That means already there is reduced anterior coverage. Now these patients, when standing, they will again have anterior dislocation. So we need to reduce the acetabular cup version while doing a total hip arthroplasty. So now we have learned all the four scenarios where we need to tweak the placement of acetabulum with respect to its anteversion and inclination, what we call the kinematic placement of acetabulum. But what should be the exact degree where we need to place the acetabulum? Nobody exactly knows. Nobody has ever tried to place the acetabulum beyond the safe zones. So we should be wary of just tweaking the acetabular version or inclination by 2 to 5 degrees or maximum by 8 degrees, not more than that. The other thing is that if you are not sure where exactly the correct version should lie, just rely on the other parameters for placing the acetabulum, which we have discussed in total hip replacement. Tweak it by 2 to 4 degrees. If you don't remember at all what should be done, maybe reduce the version or increase the version, then it is better to use the anti-dislocation cups or dual mobility cups. They are very good rescue devices. Now, that should be finishing it all? No, it is not like that. It is not always the acetabular version which is at stake. Patients who are having unilateral hip osteoarthritis along with concomitant low back pain have increased femoral neck anteversion. Now here you need to tweak the femoral neck anteversion and not the acetabular version. You need to place the total hip prosthesis in the exact position which is guided by not just placement of the acetabular cup but by femoral stem, the proper lengthening, and we should not be shortening or increasing the length of the hip joint. The approach and all other factors which we have already discussed in total hip replacement need to be in synchrony with the acetabular placement to optimize the success of total hip replacement. Okay, so now it is finished. I mean, ultimately we have to do a very good total hip replacement along with improved kinematic placement of acetabulum to increase the life of the implant in the patient and also prevent the complications like dislocations. No, aging is a very big elephant in the room. Aging is a kyphotic event, and with progressive age, the pelvis goes into retroversion. That means the acetabulum keeps on opening, so the patients may have still late dislocations and poor wear rate of the implant. The implant may be wearing much faster. We don't have any control over it, unfortunately. So what I have realized from all this exercise as a hip surgeon is that I should not be placing my acetabulum beyond the safe zones, and if at all in doubt, I need to use the alternative acetabular cup designs. Correct. Now I also pledge to place my acetabulum and adjusting all the parameters which can lead to reduced life of my prosthesis or may lead to dislocation. All done. Now what should I do if the patient is having both spine and hip pain? On the lighter side, I would say that it mostly depends on who is more stronger in your organization, the spine surgeon or the hip surgeon, and to whom the patient has shown first. If he has shown to the spine surgeon, you would guide him accordingly. If he has shown to your hip unit, then he will be guided accordingly. But logically, the answer, according to all the understanding, is that if the patient is having severe retroversion of the pelvis, as may arise in cases of ankylosing spondylitis or in patients who have excessive compensation, that means reduced sacral slope. In those patients, because the patient is unable to open up the acetabulum while sitting, so get him operated first and do a total hip replacement later. In all other scenarios, you can go for a total hip replacement first and do the spine surgery or spine fusion later, because it has been found that the rates of dislocation are very high if a patient is operated for spine surgery first and then you do a total hip replacement. I would like to thank all my viewers for being with me throughout this video. What I have not discussed is how to measure the sacral slope and the pelvic incidence. I hope these are basics and we should be able to do them as orthopedic surgeons on as usual. The other thing which I have not mentioned is what is the exact degree of acetabulum in all these four scenarios which I have discussed. I have already mentioned that you have to only tweak the version of acetabulum and its inclination, and you are not required to put them in a particular degree, because that specific degree of 35, 38, 40, 42 does not hold true for the universal population, but you have to tweak them according to the patients which you have got. And lastly, I would like to say keep busting the myths and keep improving the orthopedic practice by improving the practicalities. Thank you.